Good evening. We'll start the session sharply at 6 o'clock. So we will wait for a couple of minutes and we'll start at 6 o'clock sharp. Good evening. So some of you have already joined. I'm waiting for it to be 6 o'clock. One more minute to go. Good evening, Shahrukh. Good evening, Gaurav. Yeah. So let us start with our session. Good evening, everyone. Also welcome to the INICET Prepathon by Manipal Medes. I'm Dr. Vidya and I teach community medicine. In this session, I'll be highlighting some of the important topics that were asked in the INICET exams. And also, we will be solving some questions, previous year questions. So without much delay, let us begin with our session because I know your time is very precious with the exams just being around the corner. So let us start with the first chapter, which is concept of health and disease. So what are the important topics under this particular chapter? All right, so I'm starting with concept of health and disease chapter. Good evening, everyone. Nivesh, Bibin, Aditya, thank you all for joining. So you all know that community medicine subject is very, very important. It is a scoring subject, right? So let us start with our first chapter. It is concept of health and disease. So under this chapter, the important topics are PQLI, that is nothing but physical quality of life index, HDI, that is human development index, natural history of disease, levels of prevention and modes of intervention. So what is the first topic? PQLI. So PQLI is nothing but physical quality of life index. As I told earlier, there are 3 parameters based on which we calculate PQLI. So what are those 3 parameters? Infant mortality, life expectancy at the age of 1 and literacy. Good evening, everyone. Yeah, so PQLI is these 3 parameters. We take into consideration these 3 parameters. All of these parameters are given equal weightage, all right, and the rank or the score ranges from 0 and to 100. 0 is the worst performance and 100 is the best performance. 0 is the worst performance and 100 is the best performance, right? So what is the current PQLI for India? This is one of the frequently asked questions. I'm sure you're all aware with it. It is 117, all right? So the current PQLI, that is Physical Quality of Life Index for India, is 170. So what is HDI? It is Human Development Index. So again, this is calculated using 3 different parameters. So what are those? Knowledge, standard of living, life expectancy at birth. So here you can see I've just put both the indices together so that you can compare. So PQLI is using life expectancy at the age of 1, since it is considering infant mortality rate. All right. HDI is life expectancy at birth. And what is the current value? It is 134. All right. And the index is 0.644. So if the HDI is more than 0.8, it is very high HDI. If it is less than 0.5, it is low HDI. And for India, it is 0.644. So India is in medium category, all right, medium HDI. So this is what you need to know about PQLI and HDI. Moving on to the natural history of disease. So in this entire chapter, that is concept of health and disease, this particular slide is very, very important. If you understand this particular slide, it is like you've understood the entire chapter. And I'm sure you've seen questions from this particular slide multiple times. So let us understand this slide. So what is natural history of disease? Let us assume that a person gets infected with an organism and he develops the disease. If he doesn't take any treatment, what happens to him? The disease takes a natural course, right? So that is what is known as natural history of the disease, all right? If you intervene in some way, that is by giving, if you intervene it in some way by giving drugs or vaccines, that is not called as natural history or natural course. If you don't intervene in any way and if you just observe the individual without administering any treatment, that is called as natural history of disease. All right. So under natural history of disease, in natural history of disease, there are 2 periods. What are those 2 periods? Period of pre-pathogenesis and period of pathogenesis. Yeah. So somebody says HDI is 0.67. I recently read 0.644. You all know community medicine keeps getting updated. So maybe it is 0.67. I'll just check it and get back to you. All right. So what happens in the period of pre-pathogenesis? So as the name itself says, before the pathogenesis. So what do you mean by before pathogenesis? What is pathogenesis first of all? It is cellular level changes, tissue changes, physiological changes, pathological changes, right? So before that happens, that means, in other words, before the disease develops, that is known as period of pre-pathogenesis. See, what you can see here is the epidemiological triad. There is agent, host and environmental factors. All these 3 factors are present, but there is no interaction yet. So these 3 factors have not interacted yet. All right. So that is what is known as period of pre-pathogenesis. So what you need to remember is the risk factors are there, agent is there, but there is no interaction yet. The minute there is an interaction between the agent and host factors and also environmental factors, what happens? The disease develops. And that period is known as period of pathogenesis. So what happens here, as you can see, I hope you all can see. In the human host, there is interaction of host and the stimulus, that is agent. There is host reaction. There is early pathogenesis, early lesions, advanced disease and convalescence. What is convalescence? Recovery. So what is happening here? When there is a stimulus, the agent multiplies. Okay. So what is that process known as? Infectivity. Okay. I hope you can see. So this process is known as infectivity. What is infectivity? Ability of the organism to enter the human body and multiply is known as infectivity. The next thing is tissue and physiological changes. So what is this known as? Pathogenicity. Ability of the organism to induce cellular level changes is known as pathogenesis or induce disease. All right. All those who get infected won't develop disease. Okay. Yeah. So this is known as pathogenicity. Okay. So, and one more thing you can see here is after the clinical horizon, that is it coincides with development of signs and symptoms. And after that there is illness, disability, defect, chronic state and death. These are the different outcomes. Any disease will take 3 to 4 different outcomes. What are those? Disability, it can lead to defect, or they can recover, right? Or there can be death. So these are the different outcomes. Yeah. So in one of the exams, I'd given you this diagram and they'd ask you to identify what is clinical horizon coinciding with. So your answer should be development of signs and symptoms. I hope period of pre-pathogenesis and period of pathogenesis is clear. And moving on to the levels of prevention, this is very, very important. All of you should know this. So there are basically 4 different levels of prevention: primordial prevention, primary, secondary, and tertiary, right? So what is primordial prevention? So primordial prevention is basically before the risk factors have developed. The best example is if I go to a school and if I educate them about hazards of smoking or hazards of consumption of alcohol, that becomes primordial prevention. That particular population is not even exposed to any risk factors. Okay, it's called as virgin population. So I go to that population and educate them. That is the best example for primordial prevention. All right, and also other things like improving sanitation, eradicating poverty, all these general measures come under primordial prevention. So moving on to primary prevention. So primary prevention is applied when there is a risk factor, right? In this case, there is a risk factor, but the disease is not yet developed. As you can see, the disease is not yet developed in this period of pre-pathogenesis. That is when you apply primary prevention. So what is secondary prevention? You are applying secondary prevention in the early phases of the disease, right? So sometimes it can be before the signs and symptoms develop. Sometimes it can be after signs and symptoms develop also. And what is tertiary prevention? So in secondary prevention, disease was there, but there was no complication yet, right? Whereas in tertiary prevention, complications also have developed. I'm trying to limit the complications, all right? So this is what you need to understand. So what is primordial prevention? Before the risk factors have emerged in the population, right? What is primary prevention? Risk factor is there, but there is no disease yet. When you apply secondary prevention, early phases of the disease, right? Tertiary prevention, when the complications have developed. Okay, to prevent complications, you are using tertiary prevention. So under that, again, you need to know the modes of intervention. All right. So using this, they create some scenarios and they ask you in the exam. So you should be able to identify which level of prevention is it belonging to. All right. So under primary prevention, you have 2 modes of intervention. One is health promotion and the other one is specific protection. So under health promotion, there are 4 different strategies. So what are those 4 different strategies? Number 1, health education. Number 2, nutritional intervention. Number 3, environmental modification. And number 4, lifestyle changes. So they're all self-explanatory, right? Health education is you go to a school and explain them about hazards of smoking. There are some risk factors already, so you're explaining it to them. So that becomes primary prevention. So as you can observe, there is a slight overlap between education which we gave in primordial prevention and health education we are giving in primary prevention. So in one of the exams, it asked you a question like this. So if you see the word health education, go for primary prevention. All right. And the other examples are environmental modification. No, health education is under primary prevention. Under secondary level of prevention, we have early diagnosis and treatment. One of the students is asking, yeah. So the other 3 strategies are environmental modification. For example, if you take malaria, eliminating breeding places is the example. All right. And the next one is nutritional intervention, that is promoting good nutrition. And the last one is lifestyle changes, promoting exercise, etc. Okay. So what is specific protection? Yeah. What is specific protection? So under this, the 2 best examples are, the 2 best strategies are immunoprophylaxis and chemoprophylaxis. So what is immunoprophylaxis, my dear students? It is giving vaccines, right? What is chemoprophylaxis? It is giving drugs to prevent a particular disease. For example, if you are traveling to malaria endemic areas, you're supposed to take drugs, right, to prevent from getting infected. That is chloroquine. So that is the example for chemoprophylaxis. Okay. Along with this, there are some other modes of intervention also. Okay. I mean, other strategies also under this particular component. What are those? Fortifying salt with iron. All right. Wearing seat belts, wearing helmets, wearing masks. During the time of COVID, we all wore masks, right? That is an example for primary prevention. That is specific protection. All right. So all these things you need to know. So moving on to the secondary prevention, this is very self-explanatory. There is early diagnosis and treatment. Early diagnosis can be done on apparently healthy individuals. So if it is done on apparently healthy individuals, what is it called? It is called as screening. Very good. Before I ask the question, somebody asked, Dheeraj, very good. And then the next one is tertiary prevention. Here, what are we doing? Disability limitation and rehabilitation. So what is disability? In one word, I don't want all of you to remember the entire definition, right? There is no need to remember the definitions because it's not theory exam. You are preparing for INICET. So disability limitation is basically, what is disability? So inability to perform a task which is considered normal for that particular age and gender. So all of us are supposed to walk, sit, to be able to lie down, all those things, right? If we are not able to do that, that becomes disability because of impairment, right? And then the rehabilitation, that is restoration of function. is known as rehabilitation. So this is what is natural history of disease. So what I want all of you to focus here is this particular line, clinical horizon coincides with signs and symptoms, and you should know what is epidemiological triad and 3 different levels of prevention plus 1 more, that is primordial, and then modes of intervention under each of these categories. And there is 1 more level of prevention, right? Quaternary prevention. So what is quaternary prevention? Have you heard of this? This is to prevent overdiagnosis and overtreatment. So you can just remember this one line about quaternary prevention. So moving on to some of the questions, right, which were asked in the last 5 years INICET exams. So match the following terms with their definitions: pre-pathogenesis, early pathogenesis, clinical horizon, convalescence phase, and disability limitation. So these are the options in column A. So you need to match it with column B. Since it is a match the following, I will be just solving it because I can't see the comment section for this. Pre-pathogenesis phase is what? Epidemiological triad. You all agree with it? Early pathogenesis is incubation period. So what is incubation period, dear students? It is the time interval between the entry of organism to the development of first sign or symptom. See, he's asking spectacles and eye surgery, which level of prevention? Okay, so I would put it under secondary level of prevention because it is treatment, right? Yeah. Yeah. Good evening. Okay, so incubation period is the time interval between entry of the organism to the development of first sign or symptom. So what is extrinsic incubation period? Have you heard of extrinsic incubation period? It is the time required for the vector to become infective, okay, the mosquito to become infective in case of malaria. And then next one is median incubation period. So what is median incubation period? It is the time required for the 50% of the cases to develop. Okay, so these are the things you need to know about incubation period. The next one is what? Clinical horizon. It coincides with clinical symptoms, correct? Pre-pathogenesis is epidemiological triad. Early pathogenesis is incubation period. Convalescence is nothing but recovery, right? And disability limitation is rehabilitation. So this is how you're supposed to match if such a question is asked in your exams. Yeah. Which of the following levels of prevention is depicted in the image provided below? I want 1 or 2 of you to answer this particular question. Is it disability limitation, health promotion, primary prevention, and specific protection? And also I'm really feeling happy. I'm seeing so many comments. Okay, tell me the answer for this particular question. Which of the following levels of prevention is depicted in the image provided below? So whenever there is an image based question, you need to spend little time to observe the image. Little time is not in minutes, it is in seconds, right? 5 to 10 seconds you give and you just observe the image and tell me what level of prevention it is. Okay. See, he says spectacles are to be under tertiary prevention. See, it depends on the cause, right? For example, if I'm treating myopia or hypermetropia, so I'll give spectacles, right? That is treating. Rehabilitation is under tertiary prevention. Yeah. So the answer is Pushpapriya, correct? It is disability limitation. So Imanshu, we will go back to that question, spectacles and eye surgery later, all right? So let us continue with the questions here. Which of the following levels of prevention is depicted in the image? It is disability limitation, correctly answered by Pushpapriya. See, if you have understood the levels of prevention, this is a very easy question. See, we know there are 3 levels: primary, secondary, and tertiary. So under primary, what do we have? Early diagnosis and treatment. Under secondary, health promotion and specific protection under primary. Under secondary, early diagnosis and treatment. Under tertiary, disability limitation and rehabilitation, right? So if you know this, see, primary prevention, it includes health promotion and specific protection. So if we know this, it's very easy to identify this particular question, this particular option, because it comes under tertiary prevention. So what is happening in this image? What is the disease they're all suffering from? It is filariasis. That's why they are immersing their feet in soap water, right? So this person has developed elephantiasis also. So complication of filariasis. That's why we are supposed to do disability limitation here. So this is the key for us. All right. Moving on, which of the following is not an example of primary prevention? So now we know what is primary prevention. Another controversial question this is, I must say. So number 1, option A is addition of iron to wheat flour, giving pentavalent vaccine to children, health education about hand washing, ribavirin to close contact of meningitis patient. Actually, if you ask me, I would put all of these options under primary prevention, but if I have to choose one, I would go with health education about hand washing, because it's a general, I'm targeting all the diseases in general here, right? Whereas if you take addition of iron to wheat flour, giving pentavalent vaccine to children, ribavirin and all, it's specific. So I would go with this, but also I think all these options are correct. Okay, so the last question in this particular chapter. According to the World Health Organization, what are the components of Human Development Index? All right. So we've read this. Life expectancy at birth, literacy rate, infant mortality rate. So what is HDI? First of all, it is life expectancy at birth, literacy and standard of living. Right. B is the correct option for HDI. Yeah. So this was about concept of health and disease. Okay. In this we have understood PQLI, HDI, natural history of disease, levels of prevention and modes of intervention. Yeah. Okay, moving on to the next chapter, which is epidemiology. I don't have to tell you all know that epidemiology is very, very important chapter, right? So what are the must know topics under this particular chapter? This is very vast, but let us understand the must know topics. Epidemiological study designs, types of epidemic, cold chain, vaccine vial monitor and hand washing techniques. So let us understand the classification of epidemiological methods. So Dheeraj is saying C also, Dheeraj is saying B also. So let's go back to it. So first let us understand the different the classification of epidemiological methods. Okay, so basically epidemiological methods are of two types, observational studies and experimental studies, right? What are observational studies? You're just observing the individuals. You're not doing any kind of intervention. That is, you're not introducing any drug, vaccine, any form of intervention. Whereas experimental study, you're doing some kind of manipulation. You are introducing some form of intervention. All right. So under observational study, there are two types, descriptive and analytical. So what is descriptive? As the name itself says, it describes the population in terms of time, place and person. All right. Under that, there are various types: case report, case series, cross-sectional studies and ecological studies. I'm just going to tell you some key points about all of these study designs. So what is a case report? I'm sure you're all familiar with case taking, right? In medicine, OBG, community medicine. So what do you do usually? You take the history and you write it down. If you come across some unusual case, unique case, so if you write it down and if you want to publish it, you can do it. All right. So that becomes case report. Okay. Published case studies or case reports. You cannot publish the ones which are presenting with usual symptoms. Some unusual cases, if you write it in the form of a report and publish it, it becomes case report. So what is case series? Similar such case. I mean, it's multiple. Plural of case report, right? So you are combining more than one case report here. That is what is case series. So I hope it is clear now. So what is cross-sectional study? So two things you need to remember about cross-sectional study are, number one, it is also called as prevalence study. All right. So cross-sectional study, we estimate prevalence of the disease, for example, diabetes, or of some risk factors. For example, if I have to know the prevalence of diabetes mellitus in the entire country, I have to take a representative sample from each of the states and arrive at the prevalence. All right. So that is what is cross-sectional study for you. That is prevalence. The point number two, which you need to remember about cross-sectional study, is you're meeting the individuals at only one point of time. So if in your scenario in the MCQ, if they say the investigator has met the participant only once, then you should go with cross-sectional study. All right. So how do you remember this? Cross-sectional study is nothing but like taking, it is like taking the cross-section of the population. It is like taking a photograph. It is not like a video, right? We don't have information about what happens next. So we are just seeing them only once. So that is what is cross-section study. All right. What are the two things you need to remember again? It's also called as prevalence study. And number two, you're meeting the individuals at only one point of time. So what is ecological study? Some of the students have asked me ecological study, and most of you tend to skip this particular study design thinking it is not important, but questions have come from this particular study design also. So what is ecological study? So there are so many study designs, as you all can see. In all these study designs, individual is a unit of the study, right? For example, in case report, you were sitting with a patient and you were taking the history, right? But whereas in ecological study, populations you are comparing. Okay, the best example for this is a real example. One of the studies considered some 8 to 9 different countries, let us say 9 countries, all right? And then they took the per capita fat intake of all these countries. At the same time, they took the breast cancer incidence of all these countries and they tried to correlate these two. All right. So the countries which had breast cancer incidence, higher breast cancer incidence, if they also had higher fat intake, they correlated fat intake with breast cancer. So that is what is known as ecological studies. So population level, you're just comparing. So this is just to formulate hypothesis, to formulate assumptions. All right. So using this assumption, you can do other study designs and test it. So this is what is ecological study for you. What you need to remember about ecological study is population is the unit of the study. And point number 2 is the findings may be true at the population level. It may not be true at the individual level. That is, for example, you all know that US fat intake is more, breast cancer is more. Japan, usually they say spicy food intake is more, stomach cancer is more. But each individual in Japan who's got stomach cancer may not have eaten spicy food because there are other risk factors as well for development of stomach cancer. So that is the weakness of this particular study. However, this can be used to formulate assumptions. So another important point about descriptive studies is here you're just formulating hypothesis, that is assumptions. All right. And number 2, you're not using any comparison group. There is only one group you're observing. So moving on to the next type of study design, analytical study design. So the 2 things you need to know about analytical study designs are, number 1, you are testing the hypothesis. And number 2, you always have a comparison group, right? Case control study also has a comparison group, cohort also has a comparison group. So we are going to discuss these 2 in a little bit detail. So what is experimental epidemiology? As I mentioned earlier, there are 200 participants. There is a newer COVID-19 vaccine in the market and I want to test whether it is effective or not. So what I do is I divide the 200 participants into 2 different groups, group A and group B. So group A, I'll give this newer vaccine against COVID-19 which has come to the market, and group B, I will give placebo. Okay, if a standard drug is available or standard vaccine is available, for example, if I'm testing a vaccine against measles, there is already a standard vaccine available. In such cases, I give the group B, that is control group, the standard vaccine which is already available, that is ethical. If it is not there, what do? We give placebos, right? That is what happened with COVID-19 vaccine trials also. So that is what is experimental epidemiology for you, right? And then under that there is randomized control trial, field trial and community trial. So in case of field trial and community trial, you're not doing randomization. But in case of randomized control trial, you're doing something known as randomization. So what is this randomization? All right. Yeah. So randomization is, let us go back to the same example. So I have 200 participants with me and one of the companies, all right, well-established companies have contacted me and they've asked me to test COVID-19 vaccine efficacy. All right, so I want the results to be favorable, right? So what I do is, out of all these 200 participants, I select all those individuals who are healthy, who are not having any comorbidities into my study group, that is group A, and I'll give them the vaccine. And I'll select all those individuals who are having comorbidities into control group, that is group B, and I give them placebo. So which group will do better? Obviously, the group 1, right? Study group, because they were already doing well, right? So this is introducing bias, selection bias, right? And this doesn't allow for comparability. I cannot compare these 2 populations if I take like this. So what I have to do is randomization. So how do we do randomization? There are various ways to do it, right? For example, take a coin, flip it. If head comes, the first patient comes into the study group. How do I decide that? Again, that is based on the CHIT method. All right, there are various methods. There is also something known as computer generated random number table. So using that also I can do randomization. So this much you need to know. So now let us understand about case control study and cohort study in detail. So what are the things you should know in case control study? Design of the study, matching, odds ratio, confounding variable, nested case control study, case cohort study. I'm sure you've all seen questions, right, from all these topics. Yeah. So what is the design of the case control study? Can you tell me in one word what is case control study? I'll wait for 2 seconds. So what is case control study? Okay, I'll give you 2 options. Is it retrospective in nature or prospective in nature? Anybody? What is case control study? Is it retrospective or prospective? Yeah, somebody says disease to exposure, SJ, very correct. It is disease to exposure, that is nothing but retrospective, right? So you're starting with the deceased individuals and you're going back in time and assessing if they were exposed or not. Similarly, you are taking non-deceased individuals and going back in time and asking if they were exposed or not. So if the exposure rates are different between the deceased group and the non-deceased group, can we say that exposure and disease is associated? Yeah. So example for this is, if I have to look for the association between smoking and lung cancer, and if I am doing a case control study, so lung cancer patients will be my cases, right? And I'll go back in time and ask if they were smoking, if they are smokers, and also if they are not smokers, right? So similarly here also in the non-deceased group, that is those who are not having lung cancer, I'll go back and ask if they are if they were smoking. So if this is more than this, I can safely say that there is an association between exposure and the outcome. So that is what is case control study for you. So you just have to remember one line about this design. It starts with disease and ends with exposure status. Okay, so retrospective in nature. Yeah, what is matching? Okay, matching is very, very important. So for let me take the same example, the famous smoking and lung cancer example. So if I'm doing a study to assess the association between smoking and lung cancer, my cases are who? The ones who are having lung cancer. So for example, if I've taken a 50-year-old male as my case, my control cannot be, for that particular study, 20-year-old female. So I'm studying the effect of or influence of smoking on the development of lung cancer. If I take, if I don't match for these factors like age and gender, what may happen? Age and gender may also influence the results. So as you can see, there is a difference in the age here and there is difference in the gender also. So we all know that lung cancer, males are at more risk and it is more common with elderly individuals, right? As the age progresses, the incidence also progresses. So age and gender also will influence the results. So I don't want that to happen. I want to mask the effects of gender, age and other known variables. So I want to study the effect of smoking alone. So what should I do here? If I take 50-year male, I should take 50-year male only as my control. So that is what is known as matching. Alright. So the next thing is odds ratio. So odds ratio, how do you calculate? First you need to know how to draw a 2x2 table. So in the exams they give you scenarios and you're supposed to calculate the odds ratio. Okay, usually they give you simple calculations only. So this is A, that is exposure plus disease both present. Exposure is present but the disease is absent is B. Exposure is not there but the disease is there is C. Both are absent is D. Okay, so I won't tell you the derivation of odds ratio, but the odds ratio formula is AD divided by BC. So this is what you need to remember. So how do you interpret this? For example, if the odds ratio is 6 between smoking and lung cancer, okay, the odds of lung cancer patients being exposed to smoking is 6 times higher compared to those who are not having lung cancer. So you should start with the deceased individuals and interpret it. Alright, so that is what is odds ratio for you. So what is confounding variable? So confounding variable is also very, very important. Again, let me explain it with an example. Let us say we are studying the association between alcohol and development of esophageal cancer. Alright. So in this case, smoking can act as a confounder. Okay, what does it mean? Let us say there are 100 individuals in the cases group, that is esophageal cancer they are having, and there are 200 controls. Usually you take cases and controls in the ratio of 1:1 or maximum 1:4. Okay, and then here they don't have esophageal cancer, right? And then I'm studying the effect of alcohol on esophageal cancer. Let us assume that in this particular group 90% of them are smokers, and in this group only 10% of smokers. That is how I've selected controls. Alright, and I'm trying to study the effect of alcohol on esophageal cancer. So when I'm doing this, don't you think smoking also will influence the result, because smoking can independently lead to esophageal cancer, right? That is point number 1. The factor which can independently lead to the outcome is known as confounding variable. Point number 2, it is unequally distributed among the study and the control group. So in the study group it is 90%, in the control group it is 10%. That is feature number 2. And feature number 3 is this is associated with both exposure as well as outcome, right? Alcohol and smoking habits usually tend to coexist. Those who smoke have the habit of drinking also, and those who take drinks have the habit of smoking also. So these two habits tend to coexist. So these are the 3 different characteristics which you are supposed to remember when it comes to confounding variable. Number 1, it is unequally distributed among the study and the control group. It can independently be a risk factor. It is associated both with the exposure, right, and the outcome. So this is what is known as confounding variable. Moving on to nested case control study and case cohort study. Nested case control and case cohort. So very few points you need to remember about both of these study designs. Nested case control study and case cohort study, both of these study designs have the features of share the features of both cohort study as well as case control study. So you all know that case control study is retrospective in nature, that is it starts with deceased and ends with exposed, right? Similarly, cohort is prospective in nature, that is it starts with exposed and ends with deceased. So this nested case control and case cohort have the features of both. So what happens here? What is the design of nested case control study? So there is a cohort. So what is a cohort? It is a group of individuals who share similar characteristics, right? Plus we also have some baseline investigations done on them, like urine examination, blood examination, risk factor evaluation. So we know something about this cohort already, all right? So we are observing them, okay? For example, we are in the year 2020 and we are observing them. And in the year, and the study what we are, what we are trying to find out here is whether smoking leads to lung cancer or not. I am taking the same example again. So in the year 2025, one of them, they develop lung cancer, all right. So that becomes my case. So I am doing a case control study here, right. So I am taking one case from this cohort who has developed the disease, okay. So same year, I will take somebody who has not developed the disease as my control, okay. Same year I am taking the control. So this is case 1, case 2. So similarly, I will continue doing the same thing. In the year 2026, let us say there is one more case, I will take that, and the same year I will take the control, okay. I will continue this. It is not that every year somebody will develop. Next case may be in the year 2028. So I will continue to do that till I obtain my sample size. So what are the this is the design of the nested case control study. So 2 key points I have told you about nested case control study. Number 1 is it has features of both case control study and cohort study. Number 2, as and when the cases develop, you are selecting the controls, all right. And number 3 is, since we are obtaining the controls from this particular group, selection bias come down, all right. Usually what happens when I am doing a hospital based study, I select the cases from the hospital, that is the ones who are having lung cancer, cervical cancer, etc. But when it comes to taking the controls, it's very, very difficult. So I have to select the patients who are not having the disease, who are having some other disease, okay, who are not sharing the same characteristics, same risk factors, right. It's very difficult to obtain controls. So but here it is very easy because I have the cohort already, right, who are similar to cases in so many ways. So that is easy, right. Therefore selection bias come down. Since I am able to select the controls from this cohort, selection bias will come down, okay. So that is the next thing you need to know, okay. And also, since I already know so much about this cohort, for example, if I have to get some blood investigation reports and all, I just have to look at the reports. I have to go retrospectively and I have to look at the reports. So it saves resources. So this is what is nested case control study. So what is case cohort study? Whatever I explained for nested case control study, it is the same, okay. So there is a cohort here, okay, and we are waiting for them to, we are observing them. As and when they develop the disease, we are selecting them as cases, right. So 1, 2, 3 and 4. At the end, we are going to select the controls. So this is the difference between nested case control study and case cohort study. So the advantage of case cohort study is I can study multiple outcomes here, all right. I can study multiple outcomes. So I hope it is clear. I know it sounds complicated, but if they give you a scenario, you should be able to identify whether it is a nested case control study or a case cohort study. So moving on to cohort study. So cohort study, what is the design? You start with the exposed individual and you see how many of them will develop the disease, right? Similarly, you observe some non-exposed individuals and see if they'll develop the disease or not. So both the groups will see if they'll develop the disease or not. So that is what is cohort study, right? So what are the measures of association in case of cohort study? In case of case control study, we estimated odds ratio. In case of cohort study, we are estimating relative risk, attributable risk and population attributable risk. Alright, so let us understand how to calculate relative risk with the example of 2 by 2 table. So there is disease present, disease absent, exposure present, exposure absent. Right, this is total and here also there is total. So these are the different cells A, B, C, D, right? So what is this A plus B? Total exposed, right? This A and B is total exposed. A and C is total deceased, correct? Non-exposed is C plus D. So basically relative risk is incidence among the exposed divided by incidence among the non-exposed. So exposed is what here? A plus B. Out of that, how many actually have the disease? So incidence among the exposed divided by incidence among the non-exposed, right? C divided by C plus D. Yeah. So this is what is relative risk. So in cohort study, you can calculate incidence. That is because you're starting with the population at risk here. So for example, you're taking 100 smokers and you're following them up to see if they will develop lung cancer or not in the future, right? So since this is the population at risk, this is the denominator for incidence, if you remember, right? What is incidence? Number of new cases divided by population at risk. Since we have this data, that is population at risk, we can calculate incidence, and also there is a follow-up here. We can see if they are developing the disease or not. So cohort study, you can calculate incidence, remember, and you can calculate relative risk. The formula is incidence among the exposed divided by incidence among the non-exposed. Incidence among exposed divided by incidence among non-exposed. So what is the formula for attributable risk? Incidence among the exposed minus incidence among the non-exposed divided by incidence among the exposed. What is the formula to calculate population attributable risk? Incidence among the population minus incidence among the non-exposed divided by incidence among the population. And one more important thing is, how do you interpret relative risk? So we have understood the interpretation of odds ratio. You're starting with deceased individuals. So when you are interpreting relative risk, start with exposed individuals. Okay, so between smoking and lung cancer, if the relative risk is 6, you can say that exposed individuals, that is smokers, are at 6 times higher risk of developing lung cancer compared to non-smokers. Okay, so attributable risk will tell you what percentage of, what is the contribution, for example, if it is 80%, if attributable risk is 80% between smoking and lung cancer, you can say that 80% of the lung cancer can be attributed to smoking. Remaining 20% we don't know. It may be happening because of various other reasons, right? 80% can be explained by that particular risk factor. So that is what is known as attributable risk. Okay. So this was about different study designs. So let us understand different types of epidemics now. So you all know that, epidemic is occurrence of cases clearly in excess of expected frequency, right? That is more than 2 standard error. Okay, if the cases are more than 2 standard error, you say there is an epidemic. So there are different types of epidemic. What are the different types of epidemic? Common vehicle. There is only one vehicle, one source. Okay, there are 3 different types here. Point source. And then there is intermittent exposure and continuous exposure, right? So what is point source? The best example is food poisoning. Okay, so food poisoning, when there is an outbreak, there is a history of consumption of contaminated food from a particular hotel or restaurant, right? So that is point source epidemic, best example. And there is rapid rise in cases and there is rapid fall. Okay, there are no secondary waves. There is only one incubation period. Within one incubation period, all the cases are occurring and they're all declining also. Okay, what is intermittent exposure? Best example, a prostitute infected with gonorrhea, transmitting gonorrhea to her clients. Whenever the clients visit her, she is infecting intermittently, right? Continuous is, for example, if there is a well of contaminated water, contaminated with cholera, whenever people come and take water from there, they get infected. So that is the example for continuous. So what you need to remember in common vehicle is there is only one vehicle here. What is propagated epidemic? There is person to person transmission. All right. So the waves look something like this. Okay. There can be secondary waves also, more than one incubation period here. The best example for propagated is COVID-19. Right. There was person to person transmission there. So what is seasonal fluctuation? In some particular seasons you see some diseases more commonly. For example, if you take summer season, the current season, commonly seen diseases are GIT infections, right? So that is the best example for seasonal fluctuation. Cyclic fluctuation. What is cyclic fluctuation? If you take the example of measles epidemics usually occur every 2 to 3 years once. I mean, it is not happening now because, thanks to the immunization. But previously it used to occur every 2 to 3 years once. For example, let us take the example of COVID-19 only. There were different strains, epidemics because of different strains. The epidemic because of the same strain won't happen in the same year because the population is already immune. Some of them have developed the disease and developed immunity. Some of them have taken immunization and developed immunity, right? So it takes certain years, right, for the population to become susceptible, for the herd immunity to decrease in case of measles if you take. So that is why you see every 2 to 3 years once cyclic fluctuations, okay, in case of measles. What is long-term secular trends? It takes decades for it to show epidemic pattern. The best example is all the non-communicable diseases. You can take diabetes mellitus as the example here. So moving on to cold chain. So what is cold chain? There is a manufacturing site, right? Manufacturing site where they are manufacturing vaccines. From there to the actual vaccination site, we need to transport the vaccines, right? That should happen under proper temperature. So that process is known as cold chain, right? So what are the what are the vaccines which are highly heat sensitive and what are the vaccines which are least sensitive to heat is shown in this picture. So these are the vaccines which are highly heat sensitive. Okay, and these are the ones which are least heat sensitive. Okay, so this is what you need to know. So you have OPV here, BCG measles, and this side you have hepatitis B, meningococcal and pneumococcal. So let us look at the storage of vaccines in the refrigerators, domestic refrigerators, when they are there in the health centers, right? So you need to store measles, BCG and polio in the top shelf, all right, the freezer. T series vaccines. What are T series vaccines? All those vaccines which have T in it, right? DPT, TT, and then pentavalent, hepatitis, diluents, okay? So all these should be stored in the middle shelf. What should be stored in the bottom shelf? Ice packs, all right? So this is what you need to remember. Coming to vaccine vial monitor, again vaccine vial monitor is very, very important. There are 4 different stages. So what is stage 1? So in all the stages there is one square, inner square, and there is a circle, right? So in this what is happening? The inner square is very bright white, and the outer circle is bluish, right? And then if you take the stage 2, what happens? If you can observe, the inner square is lightly blue in color, but it is not as blue as the outer circle, right? The inner square is lighter than the outer circle basically. And stage 3 is equal color, square and the circle equal color. And in stage 4, the inner square is darker than the outer circle, alright. So these are the different stages. Now can you tell me what are the stages which we can use? 1, 2, 3, 4, there are 4 different stages. And first of all, a vaccine vial monitor, also called as VVM, is used to check the potency of vaccines. So what stage can we use the vaccine? Can you tell me? I'll give you 1 or 2 seconds time. There are 4 different stages, right? 1, 2, 3, 4. What stage can we use? Yeah, last 2 should not be used. Very good, Dheeraj. So first and second should be used, can be used, and stage 3 and stage 4 should not be used. They should be discarded. Very good. Moving on to open vial policy. So what is open vial policy? Once if you open the vaccine, you can use it up to 28 days, right? What are those vaccines? What are the vaccines which follow open vial policy? OPV, IPV, pentavalent and T series, right? T series, you know, hepatitis, DPT, TD, etc. And vaccines like measles, BCG and JE, they don't have open vial policy. They don't follow open vial policy. So now coming to universal immunization program, the schedule, this is very, very important. So let us just revise it once. So what are the vaccines which are given at birth? All right, BCG, OPV 0 dose, and hepatitis B 0 dose. These are the vaccines which are given at birth. Yeah. 6 weeks. 6 weeks, what are the vaccines given? OPV1, pentavalent 1, Rota 1. See, remember 6 weeks, 10 weeks, 14 weeks, you give OPV1, OPV, pentavalent, rotavirus 1, 2, 3, right? 6th, 10th week, 10th and 14th week, that is 1.5 months, 2.5 months, 3.5 months. You are giving OPV, pentavalent, Rota, first, second and third doses, right? And then at 6th week and 14th week, you are also giving fractional IPV and PCV. What is PCV? Pneumococcal conjugate vaccine. See, we were using only OPV before, but now we are at the verge of eradication. There are only 2 countries in the entire world which has OPV still. I mean polio still, right? That is Afghanistan and Pakistan. Rest all the countries have eliminated polio. So we have to gradually wane off from OPV and we have to give IPV. So we are in that phase now. That's why we have introduced fractional IPV 6th week and 14th week, right? And what are the vaccines which are given at 9th month? MR, measles and rubella, and vitamin A. So vitamin A should be started at 9th month and it should be continued up to 5 years. And every 6 months you should give 1 dose and totally it becomes 9 doses, right? And what is the dosage in case of children aged less than 1 year? It is 1 lakh international units. More than 1 year, it is 2 lakh international units. Orally it is given. And JE vaccine is given in endemic areas. And pneumococcal vaccine booster dose is given at 9th month. So 16 to 24 months can also be called as booster month because we are giving all the booster doses like DPT, OPV, MR and JE. Alright. 5 and 6 years we give DPT, second booster dose, and 10 and 6 years we give TD, right? And it doesn't end here. There is another component, that is pregnancy. We need to give 2 doses of tetanus toxoid. There should be 4 weeks interval. Okay, and booster dose should be given every 3 years once. Okay, if 3 years have lapsed, you need to start the schedule again. That is 2 doses 4 weeks apart. So let me ask you a couple of questions here. So why have I marked some of the vaccines in red here? BCG, OPV, MR and GE. Okay, because they're all live vaccines. Okay, so and one more important thing you all have to remember here is BCG vaccine can be given up to 1 year of age. So if it is not given at birth, if it is missed at birth, it can be given up to 1 year of age. OPV 0 dose, okay, should be given by 15 days. It can be given till 15 days. So if they come after 15 days, you can ask them to come for the next dose, that is OPV 1. So hepatitis B dose, 0 dose can be given within 24 hours. All right, after that you have to go for the next one. And then OPV and MR, right, polio vaccine and measles vaccine, they're usually given till 5 years. And then if you take all the other vaccines here, pentavalent, rota and all can be given up to 1 year. DPT can be given up to 7 years. So these are some of the important points. So again, what is pentavalent vaccine? One more important question for all of you. How many vaccines are there here? 5 different vaccines, right? What are those 5 different vaccines? DPT, hepatitis B and Hib. Hib is Haemophilus influenza B. Okay. So let us solve some of the questions now. Epidemiology PYQs from the INICET exams. Which study design is ideal to study previous research studies? So now you all have to answer. Cohort study, meta-analysis, RCT or case control study. The study design ideal to study previous research studies. Anybody? So the answer for this is meta-analysis, right? We are studying the previous research studies. Okay, cohort studies prospective in nature. RCT you are doing this is nothing but experimental epidemiology. Case control is a retrospective study. All right. So meta-analysis and systematic review I would like to discuss. So somebody is telling case control study. It is previous research studies we are studying. All right. It is not going back in time and assessing the exposure status. So the answer is meta-analysis for this. Okay. So first of all, what is meta-analysis and what is systematic review? Let us just discuss about it a little bit. Okay. So what is systematic review first? So systematic review is, for example, if I have to, when I'm sitting at my clinic and seeing patients, I have to do evidence-based practice, right? I have to refer or see evidence-based medicine and then practice, right? So for example, if I want to know whether vitamin C can protect against common cold, I have to look at the findings from the meta-analysis. Okay. So for example, if I want to know if vitamin C is really protective against common cold or not, we have to first do systematic review. Okay, so what is systematic review? So I've taken this from the PubMed. So when you put vitamin C versus common cold, so you got around 106 results. That is, there were some 106 articles related to this particular topic. That is, vitamin C protects against common cold, or vitamin C versus common cold, right? So from the year 1931 to 2024, they got around 106 results. So systematically reviewing articles, okay, related to a particular topic is known as systematic review. So there are so many databases like Cochrane database and etc. So we need to make sure we have covered all the databases in the entire world and collected compiled articles. So we need to do it in a systematic way, right? Some articles will be not published, they'll be lying down in the medical college libraries. Okay, some studies, they might have, see for example here I told vitamin C protects against common cold. Some articles may say vitamin C is actually injurious, it may lead to common cold. So I need to select all such articles, whether it is positive association, negative association, not published, all the articles should be selected and compiled. That is known as systematic review. So I'm going to review all these articles. So this is systematic review. So what is meta-analysis? So meta-analysis is I have compiled so many articles, like 100 articles related to vitamin C and common cold, let us say. Alright, I have to look at the analysis or the final results of all of those articles and do a meta-analysis. That's why the word meta-analysis. So in meta-analysis, you need to remember three different things. One is forest plot analysis. Alright. The second one is funnel plot analysis. The last one is Egger's test. Some of the important analysis under meta-analysis. So forest plot analysis usually tells us about the heterogeneity of the studies. Okay, we have taken different study designs. How was it varying? For example, in one study odds ratio may be 3, in another study odds ratio may be -2. Okay, what is the how is it varying from study to study? That is what is given in forest plot analysis. If you take funnel plot analysis and Egger's plot, these two are telling us about publication bias. Okay, so at least this much we need to remember about forest plot, funnel plot and Egger's test. Moving on to the next question. A study was conducted for testing the effect of, I want all of you to answer this question, circadian rhythm variation on fat content expressed in breast milk in mothers of preterm infants, which is the ideal study design for the study. So again, this was asked in one of the INICET exams in the last 5 years. So here I would like to see if there is any variation in the fat expressed in the breast milk. Okay, usually they say the fat content is more in the late night, early morning milk. Okay, so I want to prove that by a study design. So what kind of study design can I use? So can I use case control study? No, because case control study always starts with a deceased individual. Do I see any disease in the question? No, so we can rule it out. Cross-sectional study is what? I told you it is to study the prevalence, plus we are meeting the individuals at only one point of time. So here to see the circadian rhythm, can I meet the mothers only at once? Or can I meet them only once? I need to meet them more than once. So it is not cross-sectional study. So what is ecological study? I am comparing the populations. But what am I doing here? Mothers are the participants. So it is ruled out as well. So the answer is prospective cohort study. Alright. So that is how you can come to the answer. Arrive at the answer. So this I want all of you to answer. Which of the following statements is incorrect? So correct. Your answer is correct, Dheeraj. So which of the following statements is incorrect for the vaccine vial monitoring? Okay. Incorrect. So these words you need to see it carefully. So option A says discard if the inner square starts changing color but is lighter than the outer circle. So what stage is this? Discard if the inner square starts changing color but it is lighter than the outer circle. So this is stage 2, right? So do you want to discard stage 2? So already we got the answer, right? Let us look at the other options. Discard if the inner square is darker in color. So inner square is darker in color in which one? Stage 4. Discard when inner square and outer circle are of same color. This is what stage? Stage 3. Use if the inner square is lighter than the outer circle. That is stage 1, right? This is correct option. They want us to use it. Okay, but the option A is incorrect here. What are the contents of pentavalent vaccine? No marks for guessing. This is a very, very simple question. It is diphtheria, pertussis, tetanus. Diphtheria, pertussis, tetanus. Where is it? Haemophilus influenza and hepatitis B. So option D is the right answer for this. What are the contents of pentavalent vaccine? So sometimes you may get simple questions also like this if you're lucky, right? Yeah. There is an increase in the incidence of non-communicable diseases over past few years. So what is this type of trend? So the minute you see non-communicable diseases and describing the trend of non-communicable diseases, you need to go with the answer secular trend. So if you know the types of fluctuations, under periodical fluctuation you have cyclical and seasonal. So you can easily guess this. Alright. So the answer is secular. Correct, Dheeraj. Yeah. So in which of the following situations will you use a sanitizer, that is to kill the organisms, right? Before examining the patient, obviously because we don't want to infect the patient. After examining the patient, yes, because we don't want to acquire the infection. After touching the patient's surroundings, because organisms are everywhere, we need to wash it. And so visibly soiled. So in this case, before using the sanitizer, we need to wash it with soap, water and etc. Right? So the answer is D. Yeah. So the last slide in epidemiology, some of the important checklists to evaluate different study designs. Alright. So I'm just mentioning this because this is also very, very important, and in one of the exams they asked a question from this. So case report, to evaluate case report, we have a checklist, and that is called as CARE. Alright. So why the name CARE? They've taken CA from here and RE from here. Observational study, the checklist is called as STROBE. Just remember the checklist's names, right? Strengthening the reporting of observational studies in epidemiology. RCT, we have two, CONSORT and CASP. CONSORT is Consolidated Standards for Reporting of Trials. CASP is Critical Appraisal Skill Program. Alright. Meta-analysis is MOOS, especially if you are doing meta-analysis of observational studies. Systematic review is PRISMA. Preferred reporting items for systematic review and meta-analysis. Okay, with this I am ending epidemiology chapter. Let us begin with the next chapter, which is very, very important again, and that is screening. So let me just take a 1 minute break. Alright, all of you can take a 1 minute break too. So this is actually my water break because I've been talking for 1 hour continuously. So I'll come back in 30 seconds. Yeah, I'm back. Yeah, so let us discuss this particular chapter, screening. It is again very, very important and very simple actually. Alright, so under this chapter we have some important topics like lead time, length time bias, prescriptive screening and prospective screening, sensitivity, specificity, positive predictive value, negative predictive value. So what is lead time and length time? I'll explain it in very simple terms using a very simple example. So let us say there are two persons, person A and person B. Okay, so both of them will develop some cancer, the same cancer in the year 2000. Okay, person A also developed a cancer, say cancer X in the year 2000, and person B also developed the same cancer, that is cancer X, in the year 2000 itself. Alright, so this particular person is very conscious, is health literate. So he has the habit of undergoing frequent annual health examinations, screening examinations, etc. So what happens in the year 2002 itself, the cancer is detected. Alright, whereas this particular person doesn't have that habit, so he waits till the signs and symptoms to appear. So that is let us say 2005. Okay, so signs and symptoms have developed, then he has gone to the doctor. But this particular person went early. Alright, so who will do better? Obviously this particular person will do better, that is person A will do better, because the disease was detected in at an earlier stage compared to person B. So this advantage gained by screening is known as lead time. So what is lead time? Just one word you have to remember. Advantage gained by screening test is known as lead time. Okay, what is length time? So length time is little advanced. Even if you don't understand, it's okay. Just listen to it once and try to remember. So length time, let us take person A and person B again. Okay, so person A is suffering from a slowly progressing cancer. Okay, slowly progressing cancer. It is progressing very slowly. That is, if it is initiated within a human body in the year 2000, it takes at least 8 years for him to develop signs and symptoms. Very slowly it is progressing. Whereas person B is suffering from a disease which is rapidly progressing. So if it develops in the year 2000, in the year 2002 itself, all the signs and symptoms have occurred. Okay, so year 2000 and the signs and symptoms are developing in the year 2008. So there are 8 years, there is 8 years gap. If you take this example, 2000 he has developed, but within 2 years he has developed the disease. Alright, so who's got the higher chance of getting detected by a screening test, if at all, if we apply a screening test? Is it person A or person B? It's person A, because he's got long latent period, right? Compared to this person, we have just 2 years to administer the test, whereas here we have so many years. So he has so many years, like if he undergoes some annual examination or if there is some camp by a medical college, he may get detected, right, to have the cancer. So that is when length time bias are introduced. So when the diseases what the persons are suffering from are different, so one is slowly progressing disease, the other one is rapidly progressing disease, then we can introduce length time bias. Alright, so this is what you need to know about lead time and length time. So even if you don't understand length time, at least one word you remember about lead time, and that is advantage gained by screening test. So moving on to sensitivity, specificity. Before that, there was one more thing. What is that? Prescriptive screening and prospective screening. So what is prescriptive screening? I am sitting in my clinic. A patient who's pregnant comes to me. I order hepatitis B test. All right, that is to protect her plus the child. Right. So I'm doing it for the benefit of the mother. Right. So that becomes prescriptive screening. So what is prospective screening? Somebody who's traveling abroad comes to us for RT-PCR report. Okay, why have the airport authorities ordered or asked for COVID-19 test? That is to protect others who are traveling with him, right? So that is known as prospective screening. So you need to remember just one word about each of these screening methods. Prescriptive screening is to protect the patient herself or himself. Prospective screening is to protect others as well. Okay, so let us understand sensitivity, specificity, positive predictive value or negative predictive value. This is very, very important. It is, I mean, if you understand this particular slide, it is like you've understood entire screening chapter, right? So let us understand the table first. Thank you, SJ. Yeah, so there are 4 different cells here, right? A, B, C and D. So what is A? Truly positive. So what is there in the columns here? Disease present, disease absent. What is there in the rows? Screening test results, right? Positive, negative. So this person, I mean this particular group is called A, and they are also called as true positives. Why are they called true positives? They have the disease actually, and the screening test also shows positive result. So that is why it is called as true positive. And what is D? They don't have the disease, right? They do not have the disease, as you can see. Plus the screening test is also saying you do not have the disease. So that becomes true negative. So what is B? This person actually doesn't have the disease, but we have given him a positive result. For example, a person has come to us for HIV testing. He actually doesn't have the disease, but we have given him positive result. We are saying that you have AIDS. So imagine the situation. So that is what is false positive. It is very dangerous. Similarly, if you take C, falsely negative, he actually has the disease AIDS, but we have told him that you don't have any disease, you are healthy. So what will happen? He will go and spread it to others, right? So falsely negative also is very bad. So these are the different cells which you need to understand. So with this, let us understand what is sensitivity. So what is sensitivity? It is the ability of the test to correctly identify all those individuals who have the disease. All right. So what are the individuals who have the disease here? A plus C, right? So out of A plus C is the one who are having the disease. A are getting detected. So that is what is sensitivity. So sensitivity is basically ability of the test to correctly identify all those who have the disease. So similarly, specificity is ability to identify all those who do not have the disease. For example, if you take B plus D are the non-deceased, out of that D are truly detected to not to have the disease, right? As not having the disease. That is what is specificity. Okay. What is positive predictive value? Positive predictive value is total positives. What is total positives? A plus B, and in the numerator you have true positives. I'll explain it. And NPV is negative predictive value. In the denominator what you have? C plus D, that is all the negatives. In that, how many are truly negatives? That is D. Okay. So this is what you need to understand about sensitivity, specificity, and positive predictive value, negative predictive value. Okay. So one more important thing about this particular slide is positive predictive value depends on the prevalence. So this one important statement you need to remember. Okay. If the prevalence is higher, positive predictive value is also higher. All right. So let us say there are two villages, village 1 and there is village 2. Okay. Let us say the prevalence of COVID-19, let us take the example of COVID-19, it is 95% in village 1 and it is 5% in village 2. Okay. So there are, let us say there are 100 individuals here, and here also there are 100 individuals. So out of 100 individuals, 95 of them have the disease. Out of 100 individuals, only 5 of them have the disease. This is a low prevalent village. This is a very high prevalent village. All right. So let us say I do RT-PCR test on somebody here. I don't know who. I am just doing RT-PCR on somebody. Out of 100, on someone I do RT-PCR. Okay. And it comes positive. And in this scenario also, village 2 also, I do RT-PCR on someone and it comes as positive. Okay. So who has the higher chance of really having the disease? Is it this person or this person from village 2? It is this person because the prevalence is higher here. Okay. So what you need to remember is positive predictive value increases as the prevalence increases. Okay. So this is what you need to understand about sensitivity, specificity, PPV and NPV. And one more thing about screening test is parallel testing and testing in series. So what is parallel testing? So let us say I apply 3 different tests to detect a disease simultaneously. Parallelly I administer 3 different tests. Even if one is positive out of these 3, I am taking it as positive. So that is known as parallel testing. Alright. So what is testing in series? There are again 3 different tests I am applying, but one after the one. I will apply first test now. Only if it is positive, I will administer the second test. Similarly, if this is positive, I will administer the third test. So basically what am I trying to do here? I am trying to rule out as many as possible from the diseased group, right? Whereas here I am trying to include as many as possible to the diseased group. So in this, sensitivity increases. So when you are doing parallel testing, sensitivity increases. When you are doing testing in series, specificity increases. Okay. So this is what you need to know. And one more important thing about screening tests is, for screening test, sensitivity should be high. For a diagnostic test, specificity should be high. So moving on to the next topic. Before that, let us solve some questions related to screening. A diagnostic test has 98% sensitivity and the result comes out to be negative. The inference derived is, can you answer this? Needs further evaluation with the test of similar spectrum. Results should be discarded due to the false negativity. The disease has 2% prevalence. Is it so? If there is 98% sensitivity, does it mean there is 2% prevalence? No. The disease can be easily ruled out. Safely ruled out is the option. So if a test has 98% sensitivity, that means if 100 individuals are having the disease, this test is able to pick up at least 98 individuals. That means the test has very high sensitivity. Actually, no test is 100% sensitive or 100% protective. So if there is 98% sensitivity, it is actually very good. And if the disease, if the screening test says the result is negative, the disease is actually not there. You can easily rule it out. Next question, which of the following is related to external validity of the screening test? Alright, generalizability, objectivity and stability, repeatability. So the answer is generalizability. So I'll just explain validity. Alright, so under validity there are 2 types, internal validity and external validity. So if you remember, I had given you an example earlier while explaining cross-sectional study, right? So if I have to estimate the prevalence of diabetes mellitus in the entire nation, I have to take the representative sample from almost all the states in the country, right? If I've done that, if I've done that, I can extrapolate those results, okay, the results of my study into the entire nation. I can generalize the results. So that is what this is saying. Okay, so generalizability or external validity is the same, and external validity or generalizability can be increased by increasing the sample size. So what is internal validity? Within the study, some error I am introducing. Okay, it is also called as bias. Internal validity is nothing but systematic error or bias. It can happen during the stage of data collection, data analysis, or also in the planning stage. Okay, so that is what is generalizability for you. Generalizability is external validity, internal validity is bias. That much you can remember. So what is repeatability and validity with respect to screening test? Okay, validity and repeatability. So let us say a person's hemoglobin percentage is 10 grams. All right, as per the standard test. There is a screening test and I administer the screening test, and according to this screening test, the hemoglobin percentage is 10 grams. Alright, so that means the test is valid. It is actually giving the true value. Alright, what is reliability? I am doing the test 2 to 3 times, this newer screening test. Each time I repeat, the value is 11, 11, 11. Okay, so this is not closer to this, right? This is not 10, but each time it is giving the same value. That means it is repeatable. I mean, repeatable means reliable. Repeatability is also called as reliability. So I hope validity and repeatability or reliability is clear to you. Okay. Amongst the given options, which statement is correct? In low prevalence, the positive of the high sensitivity means true positive. I have explained the story, right? Village A, village B, think of that. So this is wrong. Sensitivity depends on prevalence. Specificity depends on prevalence. No. Positive predictive value increases with increasing prevalence. So this is the right option. Right? Okay, moving on to the next chapter, which is statistics. So I'll be teaching about statistics for the next 20 minutes. After that, last 5 minutes, I'll just talk about some of the important communicable diseases, and then we can end this session. Okay? Yeah. So let us understand the different types of scales. Very, very important, right? So there are 4 different types of scales: nominal, ordinal, interval, and ratio. So one line about all of these scales. So what is nominal scale? When we use nominal scale, it is used for named variables. All right. What are named variables? Examples: gender, male, female, or marital status, married, not married, widow. So in such cases, we use nominal scale. Very easy. What is ordinal scale? When we have ordered data, right? Like first rank, second rank, third rank, or mild, moderate, severe, right? Mild, moderate, severe. So when we are describing such data, we are going to use ordinal scale. What is interval scale? Interval scale is used, for example, in case of, to express temperature in degree or in Fahrenheit. Okay, so in such cases, we use interval scale. So one thing you need to remember, another thing you need to remember about interval scale is there is no absolute zero. There is no absolute zero in case of interval scale. What does it mean? Zero also has a value. SJ, I will teach you. If you are patient enough, I have prepared all the slides. So we will continue if you are interested. Don't worry. Okay. So in case of interval scale, there is no absolute zero. All right. What am I trying to say in this is, you know that 0 degree temperature also exists in some places, right? There is plus 10 also, 0 also, minus 10 also. So 0 has a value there. So there is no absolute zero, okay, in case of interval scale. Ratio scale, there is an absolute zero. So here we can understand the concept, but when we go to exams, what happens? We tend to forget. So how do I remember this? So it has O here, 0, right? There is an absolute zero. So for example, here weight in kg, example for ratio scalar, weight in kg, height in meters, etc. So is there zero weight? Is there zero height for anybody? No, right? It doesn't exist. So that's why you can say absolute zero is there. Zero has a value here. All right. Whereas in case of interval scale, there is no absolute zero because 0 degree temperature also exists. Okay. So this is about different types of scale. So moving on to the next slide. So in this slide, we are going to study measures of central tendency and dispersion. This is very, very important. I don't have to tell you at all. So what does arithmetic mean? Arithmetic mean is very simple. It is taking the average of all the observations, right? So let us take an example. 1, 2, 2, 3, 5. Can you all see? 6, 7, 8, 100. Okay. So how many values are there here? 5 and 4. Totally 9 values are there, right? So what is arithmetic mean? How do you calculate arithmetic mean? You take the average, that is, you sum all these observations and you divide it by the number of observations. So you do 1 plus 2 plus 2 plus 3 plus 5 till 100 divided by total number of observations, that is 9. So this is what is arithmetic mean. So what is median? You arrange them in an ascending or descending order. It is already arranged in an ascending order, correct? Sometimes in the exams they won't give you in an order. So you need to arrange it in an ascending order or descending order. Any order is fine. And you need to take the middle value, right? That is called as median. So if there are even numbers, you need to take the central 2 values and divide it by 2. What is mode? Mostly recurring value. What is that here? It is 2. So I've taken simple examples here. So this is what is arithmetic mean, median, mode. Okay, so these are basics. Let us go one level higher. So there is an extreme value here, right? 100. So do you think while calculating mean, this 100 influence the final result? Yes, right? Extreme values will affect mean. Okay, whereas in median mode there was no influence of this 100 on this or this, right? So extreme values they do not influence median or mode. Okay, you need to remember this. Extreme values affect arithmetic mean, whereas median and mode are not affected by extreme values. So going back to the previous slide, interval and ratio scale we use mean. Okay, nominal scale we use mode. For ordinal scale we use median. Okay, so this is also very, very important. For interval and ratio we are using mean, nominal we are using mode, and ordinal we are using median. Yeah. So next thing is range. So what is range? Highest value minus lowest value. Let us forget 100 now. What is the highest value? 8 minus 1. So that is what is range. Okay, what is if there is 100 in the question, you need to include 100 also. Now just for the explaining purpose I have not included it. Alright. So what is interquartile range? So if there are 100 values, 0 to 100, quartile is what? 4 parts, right? How do you divide this into 4 parts? There should be 3 intercepts. 1, 2, 3. So did we get the 4 parts here? 1, 2, 3, 4, right? So these intercepts are called as Q1, Q2 and Q3. So what is interquartile range? It is Q3 minus Q1. That is, if you take this, it is 75th percentile minus 25th percentile, right? So that is what is interquartile range. So while explaining, while giving, when they give median, they give interquartile range. When they give mean, they give standard deviation along with it, alright? So what is the next one? Mean deviation, standard deviation and variance. Yeah. So what is mean deviation? See, let us take a population. Let us say there are a few individuals there, 5 of them, 8, 9, 12, 11 and 6. These are the hemoglobin percentages of all these individuals. I take the mean, okay, let us say 10 because I don't want to calculate now. Let us say the mean is 10, that is all the observations divided by 5, right, total number of observations. So mean deviation will tell us how much each of these values, right, in the population 5 individuals were there, how much each one's value is deviating from the mean is given by mean deviation. So how do you say that? 9 minus 10, 12 minus 10, 6 minus 10, right? How much this value is deviating from the mean, how much 11 is deviating from the mean, how much 8 is deviating from the mean. So sum of all of this, that is average of all of this, is known as mean deviation. So how do you take the average for this? See, x bar is the mean, this is mean, okay? X is the individual value. So what are we doing? X minus x bar we are doing, and we are taking the average. How do you take the average? Sigma x minus x bar divided by n. So this is what is known as mean deviation. So in this what is happening is we are not considering the signs. So in this it was minus 1, okay, in this it was plus 2. So we are not considering the signs. To overcome that we have something called as standard deviation. Multiple times they have asked what is standard deviation. So standard deviation, what you have to remember is it is root mean square deviation. Root mean square deviation, alright. So since we are not considering the signs, so since we did not consider the signs in mean deviations, now we want to consider the signs. Okay, so same thing you take sigma x minus x bar divided by n. So to address this issue, we are going to, we had not considered the signs, right? So if you square it, what happens? The signs get ignored. So I am squaring it, and to overcompensate that, I am taking the square root. Alright, so this is what is the formula to calculate a root mean square deviation. Even if you don't understand the derivation of it, I want all of you to remember the formulas at least. It is sigma x minus x bar divided by n, and here it is sigma x minus x bar whole square divided by n, and the root is there, square root. Alright, so this is what is standard deviation. And what was the last one? Variance. Okay, it is standard deviation square. Okay, so the mean deviation, and also if you take the standard deviation, this is also telling how much each value is deviating from the mean. Okay, so that is what you need to know about measures of central tendency and measures of central dispersion. Measures of dispersion, sorry. So the next one is coefficient of variation. In this you need to remember the formula. Coefficient of variation is given by the formula standard deviation in the numerator, in the denominator arithmetic mean multiplied by 100. So what does it say? This coefficient of variation, level of variation. If the coefficient variation, that the CV value is less, that means there is less variation. If the level CV is more, it means that there is high variation. Alright, so that is what you need to remember. Just remember this formula. Moving on to different types of graphs. There is simple bar diagram, right? What is simple bar diagram? It is used to express tabulated data. So for example, if you have data something like, if you have data like 1901, the population was 238 millions. In the year 1921, it was 279, all right, 251. And in the year 2011, it was 1210, and I want to represent this in the form of a graph. That is when I use simple bar diagram. This is to describe one particular characteristic, single characteristic. I am just telling what was the population in 1901, 1921, 2011. Okay, that is when you use simple bar diagram. So when do you use multiple bar diagram? When you have to describe more than one characteristic. Okay, this is male literacy status, this is female literacy status in the year 1951. Similarly, male literacy status and female literacy status in the year 2011. So when I am describing two variables, I am using multiple bar diagram. What is proportional bar diagram? So you can see there are different bars here, division 1, division 2, division 3. In each division, how many patients are visiting primary health center, taluk health center, district health center, and seeking health care from the private consultants. This is what I wanted to know. So I have plotted this proportional bar diagram graph. So in this it is very easy to compare. So we can say that in division 1, very less number of patients compared to all the divisions, that is 2, 3. In division 1, less people are visiting PHC and maximum of them are going to private consultants. So like this I can make comparisons. That is when you use proportional bar diagram. So within this bar only there are different sections, as you can see. Pie diagram, so for example, to represent religions, right? So out of all the individuals, how many are Hindus? Okay, so that is when I use pie diagram. So in the entire circle, how many are actually Hindus? 70%. So that is that is when we use pie or sector diagram. What is line diagram? So line diagram, as you can see, over the years, what is the change in events? All right, a change of it basically tells us about the trend. Okay. It is showing the trend, right? So in the year 1901, it is sex ratio, it was 972. Here it is 940. So it is changing. So to show the trend, we are using line diagram. Histo or block diagram is used to express frequency distribution, right? Frequencies. When there are class intervals, okay? We use histo or block diagram. And one more thing you need to remember about histo or block diagram is, it is to describe continuous data. So here we have taken hemoglobin level in grams. It is a continuous data. So what is continuous data? There is 11.1, 11.2, right? So it is like this. Discrete data, they don't take in between values, right? So this continuous data, we use histogram or block diagram. So if you take the same histogram and identify the midpoints and join them, that becomes frequency polygon. Okay, and the last one is box and whisker plot. I'm sure you've heard of box and whisker plot. Okay, there are 5 points here: maximum, minimum, upper quartile, lower quartile, and median. So this is the box and whiskers on each side. So this is used, this is a measure of variation actually. Okay, so how much the data is deviated, that side or this side you can see. This is box and whisker plot. moving on to standard distribution. This is very, very important. Again, there are three different types of standard distributions, right? Normal distribution, which is also called as Gaussian distribution, and there is binomial distribution and Poisson distribution. So all these three things are very, very important. Many times questions have come. Normal, binomial, Poisson. Okay. So what is normal distribution? So we all know that normal distribution is bilaterally symmetrical, it is smooth, it is bell shaped, okay, and mean is 0, right? Mean, median, mode all coincide, mean, median, mode all coincide, and standard deviation is 1, and then area under curve is 1, okay. So these are certain characteristics, okay. And one more thing you need to know is mean plus or 1 minus standard plus or minus 1 standard deviation, there will be 68.3% values, plus or minus 2 standard deviation, there will be 95% values, 95.3, and if you take plus or minus 3, there will be 99.7% values. What does this mean? Okay, so for example, if the hemoglobin is, the mean is 10 gram for a population, alright, and if it is here, plus or minus 1 standard deviation, that is plus 1 is how much? 11. Minus 1 is how much? 9. So between 9 to 11 gram percentage, I mean 68% of the values will lie between 9 to 11 gram percentage. 68% of the population's hemoglobin percentages will lie between 9 to 11 gram percentage, and we usually use 95%, right? Plus or minus 2 standard deviation. So we say 95% of the values will lie between 8 to 12, right? Minus 2 plus 2. So that is what you need to know about normal distribution. So binomial distribution, you need to know only 2 points. One is it is used when the outcome is binomial in nature. That's why the name binomial. Alright, outcome is binomial. The best example is tossing a coin. So when you toss a coin, what can happen? Either head can come or tail can come. No other. Binomial distribution can be used when the data or the outcome is in binomial fashion. That is, there are two outcomes, right? Success or failure. Okay. So I was giving the example of tossing a coin. So the second important point you need to remember about this is, see, let us say 10 times I am tossing a coin, right? So first 3 times heads come. So what is the probability of heads coming in the fourth trial? Do we know? It is not known. It is independent, right? Each outcome, each event's outcome is independent on the previous outcome. So that is when you use binomial distribution. Okay, the events are independent. I know it is very difficult to understand. Just remember these two key points. It is used when the outcome is binomial in nature and the outcomes are independent on each other. It is not dependent. Alright, that is when you use binomial. So what is Poisson distribution? It is used when the events are rare. Let us say what is the probability of Apple company manufacturing defective Apple iPhones within 3 years interval. Okay, so this is the example. So it may be, it is very rare, right? But it may be there also. We don't know. It is infinite. It may be 1 also. It may be 100 also. We don't know the number. It is infinite. So in such cases, you use Poisson distribution. So we are assessing the events within a particular time frame. Point number 2, the event is rare. So in such cases, you use Poisson distribution. So these 3 important standard distributions you need to understand. So moving on to correlation and regression. So what is correlation? It is to test the relationship between 2 quantitative variables. For example, if height increases, all right, weight also increases, right? We all know that. So when you are correlating these 2 variables, we use correlation coefficient, right? The correlation coefficient is represented by R, all right? R is equal to 1. Plus 1 means there is strong correlation, okay? So when there is strong correlation, what happens? If height is increasing, weight is also increasing. So the curve will look something like this. If there is negative correlation, what happens? The curve will look like this. If height is increasing, the weight is actually decreasing. Alright. So in such cases, we use negative correlation. I mean, we cannot take weight and height example here. We can take it for positive correlation. So R is equal to plus 1 means positive correlation, minus 1 means negative correlation. R more than 0.6 to 0.7 means strong correlation, right? More than 0.6. or 0.7, some take 0.7, and if it is less than 0.3, it means it is negative, weak correlation. So what is regression? So correlation is what? With change in one variable, the other variable is also changing in the same direction. Then you can say positively correlated. Alright. So for example, if one variable is increasing, the other variable is also increasing. So this is positively correlated. If one variable is increasing, the other variable is decreasing, as negatively correlated. So similarly, regression is with one unit change in the variable, what is the change in the dependent variable? So that is what is regression. Alright. It is given by the equation y is equal to a plus bx. B is the regression coefficient, that is the symbol we use. X is the independent variable and y is the dependent variable. So this is what is regression equation. So this much you need to know about correlation and regression. So let us look at tests of significance. This is very important again. So there are two types of tests under tests of significance. One is parametric test and the other one is non-parametric test. So what are parametric tests? When do we use parametric tests? When the data is normally distributed, when the data is quantitative in nature, when the data is in the form of mean, right? That is when we use parametric tests. So when do we use non-parametric tests? When the data is not normally distributed, when it is qualitative in nature, when it is in the form of medians or scores, we use non-parametric tests. And then under parametric tests, we have z-test, t-test and ANOVA. So I'll just take one example. So there is a population. Again, I'm taking hemoglobin percentages. So there are 10 different individuals, all right, 1 to 10. And we have the hemoglobin percentages of all of these individuals, all right. So this is population A, let us say, and there is population B also. And again, I have the hemoglobin percentages of 10 different individuals in that population B, okay. And we have the means also, mean hemoglobin percentages of these two different populations. If it is not same, if there is a difference, I want to know if that difference is statistically significant or not. That is when I use z-test, all right, or t-test, okay. In t-test, again, there are two types. So basically, z-test is used to identify, it is used to test if there is statistically significant difference between the means of two different populations. There are two types, one-way ANOVA, all right, one-way and two-way. So what is one-way ANOVA? Let us say I want to compare the mean hemoglobin percentages of 3 different districts. That is when I use one-way ANOVA. I want to, when do we use two-way ANOVA, the next one. So I want to know the differences between means of 3 different villages under these 3 districts, subgroups. I am seeing the differences in the subgroups, right? That is when I use two-way ANOVA. Okay, this is what you need to remember. Okay, coming to non-parametric test, chi-square test. Chi-square test is to test the association between two variables. We all know this. And then we have Mann-Whitney's test and Wilcoxon sign rank test. So there is a mnemonic to remember. So there are some non-parametric counterparts of parametric tests, right? That is what we need to remember. So for paired t-test is what? Before and after observations, right? Same individuals. So for that, if the data is not normally distributed, if it is in the form of median or scores, I use Wilcoxon sign rank test. Okay, paired women is the mnemonic and unpaired men. Okay, unpaired men. What does M stand for? Mann-Whitney's test. So for unpaired parametric test, the non-parametric test counterpart is Mann-Whitney's test. Okay, and then we have one-way ANOVA. One-way ANOVA, the counterpart is Kruskal-Wallis test. Two-way ANOVA, Friedman's test. So I'm sure it is looking complicated. So I'll just explain it one more time within a few seconds. So z-test is used to test the difference between the means of two different populations. Unpaired t-test when the sample size is less for the same purpose. Paired t-test before after observation. Same population, before iron supplementation, what was the mean hemoglobin percentage? After iron supplementation, what is the mean hemoglobin percentage? One-way ANOVA to test the differences between the means of 3 different groups. Two-way ANOVA between 3 different subgroups. So if you have understood this much, you just have to match it with non-parametric tests. Unpaired t-test is Mann-Whitney's, paired t-test is Wilcoxon sign rank test, one-way is Kruskal-Wallis, two-way is Friedman's. So when the data is in the form of scores or qualitative, not normally distributed, you use non-parametric tests. And when data is quantitative, normally distributed, use parametric. So kappa statistic, I'm just giving you the formula. It is observed agreement minus expected agreement divided by total minus expected agreement. Okay, this is to check for the level of agreement, inter-observer variation. So if you see the word kappa statistic, inter-observer variation should come to your mind. Okay, so let us solve some questions and then let us move on to the next topics. This will take around 20 minutes. Okay, the entire session. 4 groups of homogeneous samples were taken and the height and weight of each group had a correlation coefficient of 0.6. With the help of the image, calculate the total correlation of the combined group. See, correlation is given by comparing 2 different variables. Okay, so they say it is 0.6 height and weight. That means it's actually 0.6. So it is equal to 0.6. So this is common sense question. What is a branch of statistics dealing with the method of data collection and counting? So analytical statistics, we usually calculate odds ratio, relative risk, etc. Right? Analysis. Descriptive statistics is the answer for this. It deals with data collection methods, counting, okay, describing the variables in terms of frequencies, proportions, etc. Inferential statistics is expressing the results in terms of p-value, right? So p-value usually is fixed at 0.05, right? If it is less than that, it is considered as significant. Theoretical statistics is basically all those theories. We saw standard distribution curves, right? Normal distribution, binomial, Poisson. So that is under theoretical statistics. Moving on, 2 young researchers wanted to study whether interns had the right skill of correct technique of administering an injection. Which of the following qualitative methodology would be ideal to assess the data? I want all of you to read the options and give me the correct answer. Okay, so what is the answer for this? It is questionnaire based with checklist. Using CCTV, no. In-depth interview with the health professional, answer is no. In-depth interview with the patient, he won't be aware of the correct technique. So the right technique is questionnaire based with checklist. So basically what is happening, it is basically like your exams, right? So 2 different examiners come. There is an OSPE station. You all know what is OSPE, objective specific practical examination under CBME curriculum. So they all come with different checklists. So they will all, 2 examiners will assess the same student, all right? So to see if there is any discrepancy in the examiners, right? If there is any variation. So the best answer for this is questionnaire based with checklist. All right, to see the correct technique of administering an injection. Okay, there should be steps. So the researcher should, the intern should wipe the area with spirit, identify the correct site, okay, administer the correct dose. So like that, we need to prepare checklist and compare whether they are doing it properly or not, evaluate whether they are doing it properly or not. The formula represents, it is standard deviation, right? A coefficient of variation, what is the formula? Standard deviation divided by mean into 100. Standard error, what is the formula? Standard deviation divided by square root of n. All right. Variance, what is the formula? Standard deviation square. Coefficient of variation, let me just write it down. Standard deviation divided by mean into 100. Okay, or you can write sigma divided by mean into 100. So these are the different formulas you need to remember. Which measure of dispersion best explains the difference between the highest value and the lowest value? So again, no marks for guessing this because it's a very simple question. It is a range. So you know what is coefficient of variation? Interquartile range is Q3 minus Q1. It is not highest value minus lowest value. And variance is standard deviation square. Which of the following is not a cause for widening of a confidence interval? So let me just give you an example. If you are expressing odds ratio, let us say between smoking and lung cancer, and if it is 6, we also give an interval, that is confidence interval, all right? So let us say 8 to 10, not 8 to 10, 5 to 8, okay? So within this range, the actual value is there, right? 5 to 8, this actual value is there. So that is what is confidence interval. So it is the range within which the actual value lies, okay? So if this range is very wide, it should be actually narrow. If it is very wide, it says there is increase in the confidence level, there is increase in variability, it should be actually low, I told you. And one more thing is, if there is increase in sample size, the width will be actually less and it is actually good. But if there is decrease in the sample size, the width will be very high. So the answer is very wide. So the answer is increase in sample size. So if there is increase in sample size, it doesn't cause widening of confidence interval, it actually narrows confidence interval. So that is what you need to remember. So studies should take more sample size so that the limit is also narrow. Okay, the limit is where the actual value lies. Which is the term used to describe discrete probability distribution that expresses the probability of a given number of events in a particular time frame. So the key word is particular time frame. So what do you use here? Poisson distribution, right? Normal and Gaussian almost the same. It's the same, only binomial when it is binomial in nature. Yeah, so that was about statistics, and so far we have discussed concept of health and disease, epidemiology, screening and statistics. All right, so let us move on to communicable diseases. 10 minutes, I'll just cover the important questions. A 5-year-old boy presents to emergency with a bleeding wound from bite of his pet dog, which was fully vaccinated. So let us highlight the underline the key words here. The dog was fully vaccinated. He previously completed anti-rabies immunization. So he had already completed immunization, right? 6 months ago. So another important point to notice, 6 months ago he had completed the entire course. According to the guidelines, what is the next step in management of this patient? So can anybody answer? Are you all listening? Exhausted? So these are all very, very important topics. Yeah, so the answer for this is, since he was already immunized 6 months ago, that is within 3 years, we don't have to give the entire vaccination again. Okay, we don't have to give the entire post-exposure prophylaxis, whatever that 4 doses, 5 doses again. We just have to do a re-exposure prophylaxis. Okay, so within 3 months, we just have to do, within 3 years, we have to do re-exposure prophylaxis. That is point number 1. Point number 2, if 3 years had already lapsed, we are supposed to revaccinate. We are supposed to give all the doses. And one more important point is 3 months. So if it was given within 3 months, okay, we just have to give 2 doses of re-exposure prophylaxis. So what is it? Single site 2 dose days 0 and 3. Okay, in this all the 4 doses, rabies, immunoglobulin, 4 dose, no vaccination required, all of these are wrong. So the answer is single site 2 dose days 0 and 3. Give me a second. Yeah. So the answer for this is single site 2 dose days 0 and 3. So the next question, I'm just revising the categories of bites, right? There are 3 categories: class 1, class 2 and class 3. Class 1 is slight risk, class 2 is moderate risk, and class 3 is severe risk. So what is class 1? There is just licking, touching, feeding of the animals. There is contact of intact skin with secretions, intact skin. So in such cases, nothing needs to be done. So what is class 2? It carries moderate risk. There is nibbling of uncovered skin, minor scratches or abrasions without bleeding. All right. Immediate vaccination and local treatment of the wound is required here. Class 3 is transdermal bites. There is bleeding and also contact with bats. In such cases, you need to give immediate vaccination, local treatment plus rabies immunoglobulin. All these 3 things has to be done. Okay. What are the different regimens? SN regimen, that is intramuscular regimen. In this, there are 5 doses. 5 vials are used on 0, 3, 7, 14, 28. Okay, 5 visits. The patient has to come on 5 different days. That is 0 day on the day of bite, 3rd day, 7th day, 14th day and 28th day. Zareb regimen, IM, 4 dose regimen, 4 vials are used, 3 visits. So are we doing 4 doses in 3 visits? On the first day, that is 0 day, day of bite, we are giving 2 doses, and 7th day, 21st day, 1 dose. All right, it makes 4 doses. What is 2-site intradermal regimen? Less than 2 vials are used, 4 visits. All right. So if you take this one, on the 14th day, they are not coming. All right. 0, 3, 7, 28th day, they are coming. 2 doses are given on each of these days. So these are the different regimens which you have to know. All right. Moving on to malaria. 2-3 questions from malaria have been asked. Which is the indicator of vector burden on humans in malaria? So it's a very simple question actually. So vector burden. So I am sitting here for 2 hours. So how many mosquitoes have bitten me in the last 2 hours will give the vector burden. Okay. So we are not asking for the disease burden. So very simple question. This is vector burden. So this is given by man biting rate. Okay. What is inoculation rate? Human biting rate plus sporozoite infection rate. What is human biting rate? The rate at which the humans are bitten, and sporozoite infection rate is the rate at which the sporozoites are injected, right? What is human blood index? Proportion of blood meals derived from humans by mosquito vectors. What is man biting rate? Number of bites per person per day. Yes, man biting rate. Slide positivity rate is number of slides positive divided by number of slides examined. So the best answer for this is man biting rate. According to the National Framework of Malaria Elimination in India guidelines, what is the criteria to say that a state is in the phase of intensified control? So here, this is not a simple question. We have to study for this. So let us revise the categories. So category 0 is prevention of re-establishment phase. Here, states and union territories will have 0 indigenous cases. Indigenous cases is originated within the states, right? Category 1 is elimination phase. Here, states and UTs have API less than 1. Districts also have less than 1. Pre-elimination phase is category 2, states and UTs with API less than 1. Some of their districts reporting API more than or equal to 1. Category 3 intensified control phase, states and UTs with API more than or equal to 1. Okay, so what is the answer for this? Phase of intensified control is category 3. So what is the answer? States with annual parasite index more than 1. Sorry. According to the National Center for Vector-Borne Disease Control Program, we all know that 6 diseases are covered under this. What are the available, sorry, give me a minute. Okay, so here they've asked artemether and lumefantrine dosage. So the dosage of artemether and lumefantrine is 20 mg and 120 mg. Okay, so we all know that in falciparum, if it is positive for falciparum, we give ACT AL, right? What is ACT? Artesunate combination therapy. Artesunate doses 4 mg per kg body weight. All right. Then you have AL. What is AL? Artemether and lumefantrine. What is the dose of artemether? 20 mg and lumefantrine is 120 mg. Right? That is what we read just now. Okay. This is given twice daily. So this is one combination. Another combination is ACT SP. Artesunate combination therapy, that is 4 mg per kg body weight, and sulfadoxine and pyrimethamine. So the S doses 25 mg per kg body weight, and pyrimethamine is 1.25 mg per kg body weight. Okay. Chloroquine is used in Vivax, right? Vivax chloroquine can be given for 3 days. It comes in 300 mg tablets. Primaquine should be given in Vivax for 14 days and the dosage is 0.25 milligrams per kg body weight. We have to give primaquine in case of falciparum also. The dosage is 0.75 milligrams per kg body weight. That is 1 dose on the second day. Okay, so we need to revise National Drug Policy Malaria. Okay, if you are working as a medical officer in PHC and a patient comes to you, he has both features of tuberculosis also and HIV also. So what do you do? So do you treat him for HIV first or do you treat him for tuberculosis first? So your answer should be tuberculosis. You should start ATT, anti-tubercular therapy, because some of the drugs are intolerant, right? Patients cannot tolerate. So you need to see if they are tolerating well, and then you start with ART after 2 weeks. So the answer is B, that is start ATT followed by ART after 2 weeks. Okay, so let us understand the different types of resistance. In case of tuberculosis, see, first of all, there are 2 lines of drugs. First line drugs, rifampicin, isoniazid, pyrazinamide and ethambutol. Streptomycin has been removed, right, because it is ototoxic. Ethambutol is bacteriostatic, that is, it inhibits the growth. All the others are bactericidal, they kill the Mycobacterium tuberculosis organisms. And then in second line, we have various other drugs like fluoroquinolones, capreomycin, kanamycin and etc. So let us understand 6 different types of resistance which are very, very important. What is monoresistance? Monoresistance is resistance to one of the first line antitubercular drugs. Okay, One of the first line antitubercular drugs. What is polydrug resistance? Resistance to more than one first line antitubercular drugs, but other than rifampicin and isoniazid. Okay, that is what is polydrug resistance. These two should not be there, but other than these two, any more than one should be there. Okay, what is rifampicin resistance? Resistance to only rifampicin or resistance to rifampicin with other resistance also, with resistance to other drugs also. That is what is rifampicin resistance. At least there should be resistance to rifampicin. So what is MDR, XDR and pre-XDR? So XDR, pre-XDR should come before XDR. So MDR is resistance to rifampicin plus isoniazid. Alright, at least resistance to rifampicin and isoniazid is known as multi-drug resistance. What is pre-XDR? MDR, that is rifampicin and INH, plus one of the fluoroquinolones, one fluoroquinolone, which is in the second line. Okay, that is what is pre-XDR. What is XDR? Extensive drug resistance. There is MDR, that is rifampicin plus isoniazid, one fluoroquinolone, plus one of the injectables. Okay, these three, capreomycin, kanamycin, amikacin. One of the injectables is also showing resistance. That is what is known as XDR. So diagnostic algorithm for TB. With this, I'll end the session. Okay, so there are a few more topics which I'll be covering in the next session. Okay, so diagnostic algorithm for TB is very, very important. So presumptive TB patient is there. Okay, who is a presumptive TB patient? The one who is having signs and symptoms of tuberculosis, right? And also all the people living with HIV. Okay, okay. So this people living with HIV will directly go for CB-NAT. They are not going for smear examination and chest X-ray. Okay, so presumptive TB patients, you are going to do smear examination and chest X-ray. So that is what you need to understand here. Okay. When you do smear examination and chest X-ray together, what can happen? 4 different combinations can happen. Both smear and chest X-ray may be positive. Both smear examination and chest X-ray may be negative. Smear can be positive, chest X-ray can be negative. Chest X-ray can be positive, right? And smear can be negative. Chest X-ray is positive and smear is negative. So these 4 combinations can happen. In any case, you need to do CB-NAT. So the dictum now is any setting, okay, because all the areas are considered as high MDR settings. Resistance is increasing under PMDT criteria, that is programmatic management of drug resistant tuberculosis. Alright, we do CB-NAT for everyone. Okay, CB-NAT is nucleic acid amplification test, right? It detects the nucleic acid sequence of tuberculosis organism. Alright, so when we do this, if MTB is detected, we are going to see if it is rifampicin sensitive, indeterminate or resistant. If it is sensitive, it is taken as microbiologically positive TB, confirmed TB, because smear is also positive here. If it is indeterminate, okay, we are not sure, then we are going to repeat CB-NAT on the second sample. Okay, even on the second sample, if it is indeterminate, we are going to collect fresh sample for liquid culture or line probe assay. So CB-NAT takes 9 minutes for the results to come. Okay, and LPA, with LPA we take around 2 days for the results to come. Okay, and if MTB is not detected or if it is not available, and you need to consider alternate diagnosis. And one more important thing I missed here is, if MTB it is showing resistant, then you need to treat it as resistant case. Okay, if MTB is not detected under CB-NAT, so you need to consider alternate diagnosis. If there is clinical suspicion, you can treat it as clinically positive tuberculosis. Even though all the tests are negative, if the clinical signs and symptoms are suggestive of tuberculosis, you can treat it as tuberculosis. Yeah. So this was my 2-hour session on the most important topics. I hope you all watched the session, and I hope you all liked the session. Thank you.